You are not allowed to unmute. To raise your hand, press star 5. You are allowed to unmute. To unmute yourself, press star 6.
Chris, are we ready to go, Tracy?
We're good. I was told we're going to have a remote person, but I don't see that person yet. So I don't know if I called or not. Otherwise, fine.
Is Dr. Lane remote? No, there she is. Okay. Well, we'll go ahead and call the meeting to order. So, yeah. Oh, it's Kyle?
There was a chance that
High maintenance? No. All right. I'll wait till Tracy gives me the thumbs up.
thumbs up.
Thanks, Tracy. All right, we will officially call the August 13th, 2021 Board of Health to order. Chris, are there any adjustments to the agenda or additions that I need to be aware of?
Nope.
Seeing none, we will go ahead and move forward. I call for an approval of the meeting memorandum minutes of May 14th. Is there a motion?
I'll make a motion.
Motion by Chief. Is there a second?
Second.
Second by Kyle. All in favor, please say aye.
Aye.
Motion carries. Now, moving on to our regular agenda, we have a mountain of updates to go through, and I'll turn that over to Monica or Dr. Lane for their updates. Or Josh. They want to leave you out, Josh. Okay.
Hello. Hello, everyone. Thanks for coming. I know it's been a while since we have seen each other in person. So we wanted to make sure to give you an update as the situation is fluidly changing, and we haven't had an update for a couple of months. So we'll start out just talking about our non-COVID related activities, and then we'll provide a COVID update for the city of Fishers, and then our just broad goals through the end of the year, the things that we're working on. So these are reports of the permits, inspections, vital records, the number of activities that we have. So you can see that since the beginning of the year, we've processed 1,169 of these. not super important, but we're seeing those numbers tick up from where we were last year. We weren't able to get a good handle last year as we were just starting on what the volume would be on some of these things. So this year, I think we're starting to get a better sense of what our normal activities, would look like. Restaurant permits, food truck permits, stuff like that. Communicable disease-wide, these are numbers for this year to date through July 12th. Obviously, COVID-19 is the predominant communicable disease that we see this year in the middle of a pandemic, followed closely by chlamydia and gonorrhea. This is very common. They are just very prevalent, not more so in Fishers than elsewhere, but that's just where the numbers are. You can see that we've also handled a number of much less common of the reportable conditions. We just don't report them by the number if the number is less than 5. Those are all the ones that those aren't just all the reportable diseases, those are ones that we've actually had reports on. As far as our environmental health program, this is our picture of our mosquito traps in action. I think it's pretty exciting. So we started, I know it doesn't look exciting, but it is. We started trapping as we had suggested when we reviewed this policy with the board some months ago. Once we had the first West Nile virus report in the state, which was a couple of weeks ago, and it wasn't a human case, it was a mosquito case from trapping. So once that popped up, which was in Vigo County, then we started gathering our traps and setting them out. So those are rotating throughout the parks. And other common areas. Right now, it's been super dry, so we're not getting a ton of mosquitoes, but that is also the climate where the mosquitoes that carry West Nile are more commonly found in. So we would send out an alert to our residents if we were to come back with a positive result from West Nile with the mosquitoes, but so far we haven't had anything. As far as our restaurants, those inspections are going well. Everyone is permitted. We have had a couple of closures. They were very brief. What happens in the case of a restaurant closure if we are on inspection or on whatever reason we do the inspection, whether it's in response to a customer complaint or some other reason for inspecting. We work with those restaurateurs every day, go back every day, really work with them to educate and make sure that that they're doing everything they can to get the restaurant back up and open safely for the public. So those closures have been very short and time limited. We are looking at converting some of our restaurant inspections over to a grading system. We haven't done that yet. It's going to take a fair amount of crosswalking. Right now we're on a pass, partial pass and fail criteria. That primarily is due to just the software that we use. And that was the best way to set it up in the early part of our starting at health department, but now we're really looking at how can we fine tune that and change that into more of a grading system kind of a thing, so a restaurant could get an A or a B or a C report instead of pass, partial pass, or fail. Pools, our pool inspector has been quite busy, obviously, throughout the summer. This is the busy time for pool inspections. Those seem to be going very well. That process seems to be pretty ironed out. We have been able to work closely with our parks department and the splash pads and the other pools in the area to just perform that function without any problem. We're also doing the open water testing. If you recall, we test several places in Geist as well as Lake Stonebridge and on the White River. So we test primarily for E. coli, dissolved oxygen, just to look at the health of the water. So there have been 2 abnormal reports since we started testing this season. Those are publicly available via our website for people to view. And both of those occasions were right after heavy rain, which is when we expect to see higher rates of E. coli in the water. So that's all kind of normal and as expected. We've seen that historically, even from the Hamilton County data in the past. So we are working through an alert process to notify residents when we do have these, so a more active alert process rather than them going in and checking for specifically more for water failures, and then for any kind of, like if we were to have a West Nile positive mosquito or something like that. What we're looking at is a email listserv process where a resident could sign up on that email, and then we would send out a notice that way. We've been assessing that with our business services group, and that is found to be probably the best method for now for notifying residents in a more active way than then having to go search for the results. So we're still working through that. From a population health standpoint, I can't remember if we had started this before or after our last meeting, but we do have immunization services available now for non-COVID immunizations. So this is a picture of the door. So we have started seeing patients for our Vaccines for Children program and our 317 program, which are both state-funded programs for uninsured and underinsured residents. We also can offer adult and child vaccines for people with insurance as well. So we do have a provider that allows us to bill insurance for those vaccines, which is great. So we have clinic every Tuesday afternoons by appointment only. So we have seen people utilizing that service several for each clinic. We're still getting the word out, but we're also still kind of refining that process. It's from a billing and payment source and vaccine bucket source with all the different funders. It is a little bit complicated, but we're really happy to say that we've worked through that. We've also been working on health education. I got distracted by the door, so I wanted to talk about the immunization clinic. Health education program has really been focusing on outreach with our community partners, networking with those community partners, and building that trust and that companionship, figuring out, assessing the needs of those organizations and groups, and what kind of health education programming would best serve those groups. So we're actively doing a needs assessment right now, but we also have developed quite a comprehensive curriculum, which includes being able to offer serve safe classes to our restaurants. So we've been outreaching to the restaurants to see if there's interest in receiving that training. We also have a dementia friend program where businesses or nursing homes or other persons may want to make their place safe for residents with dementia, and just kind of understand what may go into providing services for that clientele, as well as a number of other health education opportunities on more traditional topics. Vital records is going fine. We're processing birth and death certificates, paternity affidavits, and all the stuff that we need to do as a required service for the health department. Public health nursing, I mentioned the immunization clinic. We're also looking to add some more services to the clinic as time goes on. So the next service added will be TB testing. Following that, we'll be adding some form of STI testing. HIV testing is very necessary. We have to get anybody who's positive for TB has to be tested for HIV, and then having that service is important as well. So we're looking to incrementally add those basic core public health screening services, hopefully by the end of the year. Our public health nursing folks are also doing all the communicable disease follow-up, which involves a lot of coordination with the hospitals and the providers who report those diseases, and making sure that the patients are aware that anything's investigated. For example, if there's a particular kind of E. coli case in a daycare or something like that, then we go and we coordinate with the daycare so that they know that they're taking all the necessary precautions and that kind of thing. So that communicable disease report reflects the variety of different kinds of cases that we've investigated. And then we did add, since our last meeting, an emergency preparedness coordinator, and that's through grant funding from the state. So she also is filling the role of public health nurse, also on a grant fund from the state. So this is a grant-funded position. She comes to us actually from our vaccine site, so we're very excited to have her, and she also has a wealth of knowledge and experience in public health departments in other states. So we were lucky to find her here. She had recently moved to Fishers, and she's filling both roles of public health nurse and emergency preparedness coordinator. Our mental health initiative, we are, really part of the initiative that the city started some years ago, and we're working to move that forward with the rest of the coalition, which includes our community paramedicine program, HSC schools. We're working on data analysis for what our data sources are here for mental health in Fishers to really do a good assessment of that. And then what are the needs that we have moving, and how do we plan for that moving forward? How do we make an action plan out of that? So those are kind of our next steps with the mental health initiative. I will say that we applied many, many months ago, I can't even remember when, February or March, for the CDC's Public Health Associate Program. It's a long process. This is a program where the CDC funds an associate, usually an early career professional, but with some skills or expertise, and then they try to match that person with a site that has a need. So we submitted an application some months ago, and we were recently informed that we've been provisionally matched with an associate, which would fund them for 2 years, which would allow them to come here, work for us for 2 years under funding from the CDC, and that would be our point person for our mental health initiative to really dive deep and coordinate that effort and be able to devote their full time to it. So we're really, really excited about that potential. I think it's probably another month or two before we'll know for sure if they've accepted our match. It's like the dating game for public health. From a COVID control standpoint, we continue doing contact tracing. Our tracers have been a lot busier this week, than they had been over the summer months. So they're getting back into that now. Our testing site has seen increases. We've had a couple of news stories interested as they've seen lines outside the testing site. A lot of the testing sites around the state have either seriously cut back their hours or they have stopped their services. So I don't know how much of that is spilling over to us versus the need from our community, but it is still a pretty high percentage of Fishers residents that are using our site. So we're looking at about 300 a day right now coming through the site, up from 50 to 75 a day probably a month or two ago. Our vaccinations are still going. We've seen a small uptick, and I'll let Josh talk more detailed about our vaccination rates in Fishers, but our vaccination site is still going for COVID vaccines. We have seen an increase in Johnson & Johnson use in the last 2 weeks. And we've seen an overall slight uptick in vaccine rates. We're doing pop-up clinics. Hopefully you've seen this on our social media, but we have a whole pop-up team. They're at the farmers market every single week. They also come to the concert series. They were coming to the concert series every Tuesday night, and then they've done a number of pop-ups throughout the community for the local businesses. And I think we've done almost 400 shots at those pop-up clinics, which is awesome. People are definitely using them, and we're definitely seeing having a regular presence, specifically like at the farmers market and stuff that we can be at every week, allows people to know that we're going to be there, and then they pop in when they feel like they're ready. So that's been a great process. We've been communicating with our PR department, just continuing our messaging. And we have a pretty heavy push going on right now just to encourage vaccination as well. And we'll talk about a little bit of what that entails here towards the end of this. I have some questions for you guys. Josh has been doing a lot of data analysis, and I'll let him talk about that. And then just looking at our resources that we have and how we manage those. We had cut back our testing hours as well and cut back our staff. So we're looking to boost that back up now, just from a responsible use resource standpoint.
Hey, Monica, I
Yeah.
have a quick question.
Uh-huh.
You mentioned there's a slight uptick in some of the vaccination rates. Do you know anecdotally, just speaking to some of the vaccinators and nurses, why some of those folks are choosing now as opposed to June or July? I think that's a very exciting thing that we're seeing more, but have you been able to capture any of those rationales? Maybe we might be able to use some of those to encourage more?
I think that's a really great point, and that's actually one of the ideas we have that I'm going to discuss with you in a little bit is can we spread those messages? Like, what made you change now? Now, we know that some of it is from the mandates, right? The organizations that are requiring vaccination. So people are coming in to meet those expectations from their employers. But we are looking to collect some more of those anecdotal reasons. Josh, do you want to take over here?
Thanks. I didn't give Monica the number, but I think we've done 426 vaccines at like the farmer's market and other pop-ups so far. And also, just to Monica's credit, she had the ambition to submit the CDC FAP application focusing on mental health, which is an area that they haven't traditionally supported those host sites, but knowing that it's a need in our community, we're very excited that that is provisionally matched. Sorry, here. So you probably have heard everything about the Delta variant, so I won't try to recap or summarize all of it, but as you very well may know, it accounts for the vast majority of new cases. They find that out through syndromic surveillance, and right now Indiana has actually a higher proportion of sequence samples in the current month than nationwide, so 95.6 of sequence samples in Indiana are coming back as the Delta variant. And as you probably heard, it's way more transmissible. It spreads twice as easily from person to person. One infected person can infect up to 8 to 9 susceptible other individuals. So you see that on an infectious rate much closer to chickenpox or higher. So it's more contagious, as you may or may not know, than cold, seasonal flu, polio. It's actually more contagious than smallpox and Ebola. Not as lethal as those two, thankfully. But it is more deadly than measles and seasonal flu, and it does afflict, the Delta variant is causing more hospitalizations, particularly in unvaccinated and vulnerable populations. Overall, we're seeing COVID cause more hospitalizations across different groups. And just some information about the idea that COVID doesn't impact children. Typically you see with seasonal flu hospitalizations for influenza-like illness for children 12 to 17, that's typically around like the low teens per 100,000. COVID is much closer to 35 overall for the current pandemic for children 12 to 17. So our COVID case rates were looking swimmingly well at the end of June and the beginning of July. I apologize for this graph because it should have included August 3rd through 9th. The most current week that we can reliably say these are confirmed cases. And it's just an age-specific case rate per 1,000 individuals. So if I had included the right figure, you would see that 20 to 29-year-olds are up at 2.9, not 2.2 cases per 1,000 individuals. And that would be followed next by 12 to 15-year-olds. It would just be right over 2. And then there's a host of age groups that are in the 1.9 range. Our age-specific case rates were all below 0.5 as recently as the beginning of July. And the 30-day increase across these have been quite dramatic for some groups. It's been as high as 500% increase since the first full week of July till now. So we're definitely seeing COVID cases go up here, everywhere. The Delta variant is obviously a very large contributor to that. We recently moved up on our community risk rating scale to yellow after having seen a stable increase in these cases against our metrics. There's been a 6-fold increase in cases in the first 10 days so far in August compared to the first 10 days in July. Case incidence rate has went up 10-fold from 2 to 23.9. Testing positivity for unique individuals is back in the double digits here, elsewhere. And as I mentioned, the age-specific case rates for all of our groups are increasing. And so we're seeing numbers that are much closer to what we experienced in February. So right now in the gray, I apologize, this is so small, but on the graph of the cases over time, the red line is the 7-day average of cases. And the gray area just indicates that's a preliminary period, but there are at least confirmed cases, so those numbers won't go down. That plots all the way up until August 10th. And so the 7-day average on August 10th is right around 25, just over 25 cases. That's the same as it was on February 5th. So we haven't had 25-day average since February 5th. Our new cases in the past 14 days, 267. And our total cases over time is right at 11,585, I believe. But we know the path forward through this, vaccination, particularly for those that are eligible, and then layered mitigation strategies for those that are more vulnerable or not eligible for vaccination. It was really nice today to receive the new vaccination data from the states. We get that each Friday. I loaded it in. We officially passed 75% of our eligible population fully vaccinated. That's among an estimated roughly a little over 78,000 individuals, 12 or older in Fishers. Now we know our population is growing fast, so that probably have more than 78,000. But either way, it's really nice to see us hit 3/4 of the eligible people, but that still leaves just under 18,000, so 17,800 or so on the estimates of people that are eligible and have been eligible for a significant portion of time that haven't yet engaged with the vaccination process. So as Monica has mentioned, we are wanting to really engage with those individuals, help them understand what the benefits and any risks that they may perceive are, but we know that vaccination is the best plan forward. And I will just say anecdotally, having worked in a lot of different locations and countries, the one thing that I will take away from this job whenever I leave is being able to be at a farmer's market and work through a family with 2 teenage children who had all delayed getting vaccinated for 3 months, and helping them discuss through their concerns, and then watching them walk over and go get their vaccine that same day. So that was really special. So we know the vaccine is highly protective. We know that it helps protect against severe outcomes, and we know that if individuals engage with that process, health education can be vital there to help them understand why it would be beneficial for themselves, their loved ones, and their community. And now I think I'll kick it back to Monica.
One quick question, Josh,
Yes.
if I could. As you showed the market increase in the number of people contracting COVID over the last, let's say, 14 days, 21 days, what percentage of those are unvaccinated individuals versus vaccinated?
Yeah, so you do hear this a lot. Individuals or different organizations talking about what's the breakthrough rate. So in Fishers, we get confirmed sequenced breakthrough data from the states, roughly with a 1 to 2 week look back. So we have data all the way through August 6th of 130 confirmed breakthrough cases. On August 6th, we had roughly 56,000, 57,000 individuals fully vaccinated at that point in time. When you look at the proportion all time of breakthrough cases to cases in the unvaccinated, it's 99%, right? If you look at it more towards when has Delta really become predominant, we're much closer to the 90% of cases are in unvaccinated. There has not been a tremendous amount of research is saying what's the ability of Delta to contribute to breakthrough cases.
So is it fair in general to say that 90% of the people on average that are contracting COVID on a daily basis are unvaccinated right now, based on?
I say I would say that is fair, but it's probably better to frame it as 90% of the cases are occurring in those that are unvaccinated or ineligible for vaccines.
Yeah, okay.
See if this is on. All right. My, going on the breakthrough question, it sounds like we have a high vaccination rate in Fishers. I mean, 76% of that, of the eligible people?
Of eligible, 12 to 18, but when you think about it over the total population, it's much closer to around 61%.
So why because of the under 12 age you're talking about?
Yes, there's a high number of under 12. I think it's around 17,000 at least.
Okay, so then on those people, are we measuring, I mean, so we have 76.8% of people that have been vaccinated.
For at least first dose, 76.8 have received at least their first dose.
Do we have the double dose or like fully vaccinated?
75.1.
Okay, so are we measuring like the cases that are coming back positive, I'm assuming we're getting the age that are 12 and up.
Say that again, I'm sorry.
The people that are testing positive, we're able to measure which ones have been eligible to get vaccinated.
Yes.
And that number is 11.5%? Or what does that number stand at?
Which
People that
number
are testing
exactly?
positive, what's the 7-day average?
Oh, the percent positivity?
Yeah,
That's of unique individuals. So when anybody goes in for testing, right, you can have 1,000 tests a day, and you can have 800 people go in, right?
right.
I mean, I know that doesn't make sense, but a day is not a good time frame. But percent positivity for unique individuals is the unique number of people tested and the unique positives from those tests, right?
Yeah.
Where you look at like all test positivity, that's the raw number, all of the tests that were administered divided by the number of positives over whichever time frame you define. So if you define that over a 7-day period, and you have instances where you need to have repeat testing, say it's for your workplace, right? You're then adding more numbers to the denominator. So when we look at the unique individual, we can have a closer idea of how many actual cases are out there. But when you're above 3 to 5% on all test positivity, means that you're not capturing enough.
Yeah.
Well, but I think
Cases.
maybe, and you correct me if I'm wrong here, I think one of the questions we're driving at is do you have a measure of the percentage of the ineligible population that is contracting COVID?
Yes.
Thank you.
Is that,
I'm just trying to tweak it out because you throw out, when I hear numbers all the time and everywhere, and it's just like, you can't do much about the ineligible people.
right.
So what I can say is, right now, without having to actually recalculate something else, if we look at the week of July 6th through 12th, that's just 7-day period compared to August 3rd through 9th. And we look at age-specific case rate increase, right? The highest age-specific case rate increase has been in 50 to 59 at 767% increase. The next highest is 12 to 15. That age-specific case rate has increased 550%.
But both of those are eligible for the vaccine.
Yes.
Yeah,
Under
and-
12,
And when
under 12 has increased 250% over that 30-day.
right, but I understand 250%, but I can also say if one person goes to 2 people, that's 100% increase, right?
Yep, so raw numbers on under 12, they went from 4 to 28.
Okay.
8 to 28, sorry.
And out of how many total population?
For estimated under 12, that's roughly 14,906.
So 28 people out of the 14,000. My question then
For
would
the
be...
last 6 days.
Yeah, in the last 6 days. My question would be then, in the older people, say the 60, 70 age group, 80 age group, do we have a number there where those people are?
The number of people that are 80 or older that are our residents that had COVID August 3rd through 9th is 2.
2?
2.
And that's what age group?
80 or older. We have roughly a population of 2,500 or so of 80 or older
What about
residents.
the 50 to 59 was the category that you
50 to
said?
59, 26 cases in the last 6 days.
I guess what I'm getting at is I'm trying to figure out if there's a,
What's the best measure to look at?
trying to push people to get a vaccine where I think people have dug themselves that they're either not going to get it or whatever. Trying to tell a parent to get a 12-year-old a vaccine that's I don't know what it is, but where you have numbers that are not, they're kind of questionable, versus I can say to someone who's 70 years old, the risk of you having severe morbidity, mortality, I think that's where we're missing the message here. So it would be nice if we had those numbers that support, hey, listen, you people in the nursing home that have not been vaccinated, you're playing a dangerous game here.
I think it's the opportunity for us to look at what's the health impact of getting COVID and understand the risk level is a lot more clear at this time and present. I think what's more difficult for us to understand is what is the longer term impact of COVID in someone who has a lower risk profile. So if children tend to have a lower mortality rate from COVID, Is mortality the endpoint that we should only consider? How does an infectious disease like COVID, getting into a number of children, disrupt their mental, social, emotional, and health well-being, and what will the long-term impact of that be, right?
I think, and this is probably the point of the slide that you had moving forward about how we deal with this, because this is core to the question. I think the effort we want to undertake is how do we educate people? I think they're less scared of the risks of COVID than they are of the misinformation they may be getting about the vaccine. And so how do we either disarm them with information around the misinformation that's occurring around the vaccine and try to help with that? Because if we look at our vaccination rates, we were doing very, very well. We were accomplishing our mission, so to speak, and then we plateaued, and where we underperformed was in the 20 to 40-year-olds.
Yeah, so right now, our 20 to 29-year-olds have age-specific case rate that's at least 1.5 times higher than the next age group, and they also have the second lowest vaccination coverage, and they've been eligible for.
And then I think this goes to your point about how do you articulate to a 20 to 29-year-old the importance of the vaccination. And I'm sure you guys are doing this when you're,
I mean, that's a challenge everywhere, too. It's not a challenge born and unique to us, even though that we have a population that has its own characteristics. There are some baseline similarities across how you can message this thing and go forward. I do think that helping individuals that are younger, like the 20 to 29-year-olds, understand the potential risk profile, but also the potential for other types of injury or harm that are caused not necessarily from hospitalization.
Kyle, I'd be interested, you're up at Purdue doing this work. That's obviously the key demographic we're talking about here that we're trying to, what efforts are underway there in terms of trying to motivate people to get a vaccine?
Well, a lot. You'll see, even things you're mentioning up here, the idea of just events, outreach, marketing, incentives are big, both intrinsic and extrinsic. So the idea that, so Purdue's giving away in-state tuition. You can register, it's the $10,000 check
Gotcha.
for 1 year of tuition. That was a big one for students to get that. And we're seeing that. But in terms of things that Purdue's not doing, but that people are doing around them, we're finding that popular musicians are requiring vaccination cards to go to concerts, or bars, eateries, something that's cool, something you want to be a part of, that you're finding there's a certain crowd that may not even necessarily be resistant. They're just indifferent, and they're busy. The 20-year-olds are starting work, they're doing jobs, they're, it's not just bad people making interesting choices, it's just, there's just some very busy people too. And so we find that there are other social pressures that says, hey, I get it, you're busy, but we're all going out on Saturday night, or in 2 weeks, go get the J&J, roll up your sleeve, we can all go to this concert together.
Right.
That's the kind of thing that we can't apply that pressure or force or mandate. It's just something we're seeing anecdotally. Again, some of those stories we're hearing from students saying, yeah, the pressure, I get it, Purdue wants me to, but what I really want to do while I'm at Purdue is hang out with my friends.
Right.
Yeah.
Yeah, we should tell Ruoff, they're mandating, I got this, they're mandating the vaccine or a negative test. All right. Hey, get the vaccine and win a backstage pass.
Yeah, there you go. It's a real, this is, Monica, we're having this conversation in anticipation of the FDA approval, final approval of these. How can we really be well positioned to go capture the largest portion of that 18,000 residents, or 17,750 that has still not been vaccinated, and trying to figure out those strategies is what we're really trying to figure out. How do you go get them? And that was one thing I think, Monica, we did want to talk about today with our physicians in the room. Monica has said that there are studies that show that the most impactful opportunity to try to persuade someone is in that doctor's office. And so I would just be curious from your guys' perspective what that looks like when you're having those discussions. And is there a coordinated effort? Is there a worthwhile endeavor for our health department to try to work with our local physicians to try to have those conversations? Or is that something that's you're already having those discussions when you're talking to patients?
It's a combination of both, because by the time they come to the ER, they've already developed symptoms.
Yeah.
And that's the frustrating part of it. This should have been done before that point. So, and that's true. It's more preventive, and it's more, but like I said, by the time they come to me, it's more reactive. It's like this should have been handled earlier.
Right.
And either they're really, really sick, have to be hospitalized at that point and put on oxygen, or they have to quarantine themselves and, hope for the best and hope that things don't get worse. So that's a frustration I see day in, day out in my emergency rooms.
Yeah, and working in the emergency department also, it's unfortunately the people I see that are already, the ones that are getting admitted are majority, 90+% are the ones that are unvaccinated. But unfortunately, the ones who are not unvaccinated are also very adamant. They've dug their heels in. They don't care. I mean, there's probably a sliver, and the studies have supported this. Unfortunately, the studies have shown that there's people out there that are not. They're not going to get vaccinated no matter what. It's the way to reach the people that are on the fence. And I think part of the issue is that the FDA has not approved this yet, and I understand that it's coming around. So I think once you get that, we'll see more. But other than that, I don't think you're going to reach the people that have really dug their heels in.
What are your thoughts, Dr. Lane?
I think there's a component of that. Obviously, you guys see patients in an acute setting, and I think I have, primary care physicians or OBGYNs have a unique opportunity in that we have relationships with the patients. I think the barrier for us is that right now we don't have the vaccine in the office. And so I know Pfizer has talked about single-dose vials. I think that would go a long way. And we are strapped in many ways in that there are staffing shortages. Unlike earlier in the pandemic, we're seeing our numbers go up as far as COVID patients, but we haven't stopped services. So we are doing all of the surgeries and we have all of the illnesses that we had pre-COVID now with lots of beds taken up with COVID patients. And so that strain, adding another layer, although this is exceedingly important, onto the ambulatory offices that are facing staffing shortages is complicating things. But I think if I could say to a patient, hey, we have J&J here, or we have Pfizer here, and we could give it to you, I do think that we can move the needle some. I agree with you that there are some patients that they've drawn their line in the sand, and they don't feel like they'll cross it. But I do think that if I could offer it to patients, I think that many of which I've known for many years, I think that it would make a difference.
Yeah, I'm sure it's exceptional impediment. You go through the conversation, you get them to a point where they're ready, and then you say, go schedule an appointment somewhere. The likelihood of them doing that is,
Yeah.
I don't know if that's an opportunity for us to partner in some way with primary care physicians.
I don't know what a partnership would look like right now, because there aren't single-dose vials. It would look like wasting vaccine whenever they come up with an odd number. But frankly, that's what everybody's doing right now, because it's more important to get those people vaccinated than to conserve that vaccine like we were having to do early in the pandemic. Pfizer and Johnson & Johnson are both 6-dose vials. If you can get anything more than 0 vaccinated, then it's still considered a win. There is a mechanism for private providers to sign up to be a vaccine site for their patients. And so that's the next push, is really getting it into all the places where all the other vaccines are. It's just less convenient because it's not in a single dose vial, which is what we're used to with most vaccines at this point.
And I think the other thing, and you can tell when you go to the vaccine clinic, there's also a lot of administrative work that has to happen.
Mm-hmm.
And I think that's another layer that is a barrier for, just transparently, I think, for providers every day in the offices.
Sure.
I had a quick question actually for Dr. Lane. I think specifically to one of those age groups, ideally the 20 to 39-year-olds. One of the things we've also been facing, there was a fair bit of very scary misinformation a number of months back about reproductive health and the vaccine. And I didn't know if there's anything that you've seen in your colleagues or how you're handling that, or how you're able to talk to patients, because again, it truly was misinformation, but it's terrifying. And I think that this age group would certainly be, you even just hear a whisper of that, and that might be your deciding factor. I didn't know if that's something you're seeing or how you might be able to help folks out.
No, I think that's a really good point. None of our governing bodies, whether it's ACOG or the Society for Fertility, have said that there's any evidence to suggest that there are fertility issues. However, these, vaccines were not studied in pregnant women. They, obviously haven't been out for a very long time. So it's, this is all information that is evolving. But I think that we feel confident that like many vaccines, what we tell, patients is that, in that immediate 2 to 3 month period of time, that's when the risk of, complications exists mostly. And so we feel very confident that it's not going to impact fertility. But I do think that that is something that particularly young women and some young men are taking, into consideration and very seriously. And at Community Health Network, I do think that we've had a fair number of female employees that was their line in the sand, because we are mandating vaccines in our organization.
Thank you very much.
Monica, other thoughts on this? I know you had some questions.
Yeah, so I mean, we've kind of talked through a lot of these ideas, and I really appreciate Kyle's thoughts on the folks that just need someone to push them and make them get vaccinated so they can go to a concert or something like that. Because I do think that in the 20 to 39-year-old category, it's not the most important thing in their life right now, right? But it's important to the health of the community that everyone be vaccinated so that we can all move forward. But it's a little bit harder of a concept to get across. So at any rate, our lowest vaccination rates in our community right now are 12 to 15-year-olds who have been eligible for the least amount of time, and they're, Josh probably has the figures memorized.
58%.
Huh?
58%.
58%.
At least first dose.
58% vaccinated. And then our 20 to 39-year-olds are the next two groups, 20 to 29 and 30 to 39-year-olds, and they're, I think, just over 60% vaccinated.
68% first dose, at least first dose, 20 to 29, 62% for 30 to 39.
68% and 62%, yeah. Our 16 to 19-year-olds are over 75%, so they're doing amazingly.
85%.
85%, oh, it jumped again. We don't know how much of that is from back to school or from, high school kids, understanding that they want to stay in their sports and their school activities and that kind of thing, and that they won't have to quarantine if they're vaccinated. So I don't know which of those things is driving that the most, but these are our groups that we need to target the most because these are where we have the most gain. So we're looking at some aggressive outreach and marketing efforts. I know, Sal, you mentioned Klipsch. I understand we have some radio broadcasts going out encouraging vaccination. I was just notified of that today. Our PR department is pushing that out. We're also looking at perhaps some larger events at some of our apartment complexes in our community, particularly the ones where we see the lowest vaccination rates. So we're looking, to figure out how we can encourage people to get vaccinated in larger settings like that, where we have the most to gain. Say, okay, this apartment complex has a lot of 20 to 39-year-olds. Let's hit this complex with a large-scale pop-up clinic, essentially make it really fun, maybe offer some incentives of some kind. So if you guys have ideas on that. My understanding of the research is that lotteries are more effective than small prizes. So people like the raffle for whatever reason, the raffle concept or the lottery concept. Or, how do we reach those groups? What are some other tactics aside from, businesses and fun activities mandating them? What are some things that we can do to kind of broaden this reach and really get it up there? We are doing much better than the rest of the state, so I don't want anybody to think that we're not, but we're not doing good enough. We set our expectations really high in Fishers, so we want to do better. We know we can do better, and so we just need to figure out how to get to those people that haven't dug their heels in, which I think is a very small percentage.
Any thoughts or additional questions? I think the charge here is not necessarily to come up with a brilliant answer here, but really, if you guys in your respective fields or just going home thinking about it, anything, we're willing to get as creative as we need to be able to accomplish this, because as Josh and Monica said, I mean, the path forward is clear. I mean, we get vaccinated, economically we're resilient, health-wise we're resilient. I mean, there is a path forward, and we've done really well. But to get across that finish line, we might just have to be a little unorthodox in our tactics to try to accomplish that final push. So anything you guys could think of in the interim, as we really are trying to gear up for anticipation of the FDA approval, to really be able to be out in the community and try to encourage anyone and everyone to go get vaccinated.
Mm-hmm.
I have a question for the board, and just a point of discussion. What about our younger residents that are not vaccine eligible, i.e. the less than 12-year-olds? And correct me if I'm wrong, but HSC does not require masks. It's an option within the school. On the buses, I agree that, they're requiring masks, and this may not be something we solve today, but should we make that a mandate in school until they become vaccine eligible? What are your guys' thoughts on that?
No.
What's that? Well, I've had a lot of parents reach out to me personally and saying they're just very frustrated, they're afraid, they're scared, because these kids are not eligible, and it only takes, I know, what you meant, 28 cases, less than 12?
Yeah, well, so you think about it now, right? You might think 28 cases doesn't mean a whole lot. It's not.
But it only
large
takes
number,
one
but
sick
it
child.
only takes one, right?
Right.
And if this spreads 4 to 5 times more easily
Right.
than the previous strains, 28 cases can lead to 208.
Exactly.
I can't do all the math right off the top of my head, right? But the ability for it to spread goes out further. And to one of the board, Saul, board members' comment earlier, while we can have some hard and fast and mental heuristics to help us understand, well, there's a risk profile for someone really old, and this might happen to them. We don't know what might and can happen to individuals that, while they might not have an acute health outcome that leads to hospitalization or death, we don't know what the medium and long term.
So I think a couple things here. One, we've been in constant conversations with Dr. Stokes, and I think she has a firm grasp of the situation and is continuing to monitor. And I don't believe it's a matter of her being afraid to make that decision when the numbers warrant it or she decides that it's appropriate. Also, from a mandate perspective, keep in mind state law has changed where our ability to issue public health orders are limited. You can recommend things, but ultimately city council would have to provide a mandate in that regard. But I do want to encourage you or any of the residents thinking about this is that I in our conversations with Dr. Stokes, I don't think it's we're never going to do this, we're not supportive. I think they're monitoring the situation and will adapt accordingly if they see the need. That I do believe in my conversations with her.
I don't, I understand there's misinformation, but when I give facts and information, I get judged because I'm not towing the line or filling the narrative of what should be going on. So here's a fact. The number of deaths for COVID for kids 0 to 17 has been, I think, a little bit over 400, and that's in a year and a half. Then I give a fact that RSV kills, per the CDC website, 100 to 500 kids age 0 to 5 annually. Do we mandate masks for little kids going to preschool? Because RSV kills 100 to 500 a year.
I think these are.
And then I hear that there's MISC, and that's hit about 4,000 plus kids, and I think it's a little bit less if you do a rolling average. But you're talking about 75 million kids. And so we're talking about 4,000 cases of that miscellaneous complex, multi-system, whatever it is. So those are the numbers I'm giving. I'm not saying I'm against mandates, I'm not saying I'm against masks, but those are the numbers I am fed. And I am able to make a decision based on those numbers. So there's one thing when I say misinformation, and there's another thing when there's fear. So take it what it is, but if there's a concern about not wearing masks in school, then I think your kid should wear a mask in school. That's all.
The problem is when you give kids an option, they're going to choose not to, right? So
The kid should not have an option. The parent should tell the kid they need to wear a mask.
But if it's not mandatory, they won't.
I can't help that
And the
kid.
teachers can't enforce it if it's not mandatory.
Well, clearly, different opinions and different views on this particular issue. But I think Monica has done a wonderful job staying in contact with our schools and providing information and resources. And I think, again, what I would tell you is Dr. Stokes is watching this every single day and evaluating and deciding what's in the best interest of the schools. And I have the utmost confidence in her ability to make a decision and craft a path moving forward for our students and our families.
Okay, so just to wrap up, These are just some of our focus areas for the remainder of the year, just so you have an idea of what we're working on. Obviously, we're continuing our COVID response activities as the highest priority right now. We're also working to kind of start the process of a community health needs assessment, expanding our immunization services, as I mentioned, our clinic services, I should be more specific, and then completing our data analysis for our mental health initiative and hopefully welcoming that public health fellow. Any questions or anything else?
Any other questions? Dr. Lane, anything you'd like to add?
No, I'd just like to thank Monica and Josh for their leadership, you know, the innovative ideas. You know, I think that it's hard to believe it's been over a year. And I think we all thought we'd be a little bit different place with vaccinations, but I think there's a lot to be proud of, at least for me in medicine. You know, practicing in an office, I think that we focus on what's good for that individual patient, and I think hopefully the board members in these roles understand now we have to think about what's good for the whole. I think that's what's different about public health, and I think that, you know, you guys have done an outstanding job, that we're ensuring that we're not focused on one or two people, but the whole, and what's best for the greater good of the community. So, you know, I hope that continues to be our focus.
So our next meeting, barring any sudden need for you know, an impromptu meeting, would be September 17th. Is that correct? Based on those
Yeah, that's
spreadsheet-
what's
or the
currently scheduled.
PowerPoint?
Mhm.
Okay.
Yep.
Seeing no other items, is there a motion to adjourn? Is there a second? All those in favor, please say aye. Aye. Motion carries.